Welcome. My name is Robin Young. I'm the publisher of Orthopedics This Week and the sponsor of the annual Spine Technology Awards. We have a really terrific masterclass tonight. Our topic is one of the most popular approaches to spine surgery ever developed, the lateral approach. The lateral approach has never stopped evolving, and companies like our sponsor tonight, Spineology, are a big reason for that, as you will see. The four members of our master faculty will discuss using the lateral approach combined with some innovative implant and procedure techniques to treat a broader patient population and, frankly, to raise the bar in terms of outcomes and operating room efficiencies. So I'd like to begin first with a thank you to our sponsor, Spineology, and our faculty for putting together what I think you're going to find is one of our very best master classes yet. And speaking of that master faculty, starting us off is Dr. Brandon Strenge. Dr. Strenge, one of the founding members of the Orthopedic Institute of Western Kentucky, is a fellowship-trained orthopedic spine surgeon, and he specializes in MIS and motion-preserving spine surgery. He has extensive clinical research experience, and like really all of our faculty tonight, it was a PI for several major spine surgery innovations, which today have become standard of care. Dr. Strange's fellowship in spine surgery was with some folks I know you've seen on the podium a lot, Rick Delamarter, Michael Kropp, and Hun Bai. Our next master faculty member is Dr. Pierce Nunley. Dr. Nunley, who has been a principal investigator in more than 30 studies, is also an internationally renowned spine surgeon and scientist. He's an assistant professor at the Department of Orthopedic Surgery at LSU. And one interesting aspect of his background, he did his fellowship at the University of Basel in Switzerland. He's the chairman of the American Board of Spine Surgery, and he, again, like all of our master faculty, belongs to a number of professional spine societies. He's the associate editor for the Spine Journal, and his day job is as director of the Spine Institute of Louisiana. Our next faculty member is Dr. Muhammad Abd El-Bar. He's an assistant professor in the Department of Neurosurgery at Duke University Health System. He did his fellowship at Brigham and Women's, and he is also a leader in and is particularly focused on MIS spine surgery. I found it really interesting that he is particularly focused on endoscopic and awake spine surgery, and really the fascinating topic of brain-machine interface and neuroregeneration. Rounding out this great faculty is Dr. Larry Koo, the director of the Spine Clinic in Los Angeles, and also an internationally renowned thought leader and frequent podium speaker on the subject of MIS spine surgery. His degree comes from Yale University School of Medicine, where he graduated with magna cum laude honors. His fellowship was at the Chicago Institute of Neurosurgery and Neuroresearch, but before that, he was the chief resident in neurosurgery at USC in Los Angeles. He is also a frequent podium speaker. So here's the question. Where can we go with lateral lumbar interbody fusion? Since it was introduced 25 years ago, it's become one of the most routinely successful spine fusion techniques, but it keeps evolving. And with advances in implants and instrumentation, the question is, could the lateral approach be used with more patients, become more efficient, more tissue sparing, and more of a leading MIS procedure? So Dr. Strenge will start us off by describing the evolution of lateral lumbar surgery. Dr. Strenge, it is an honor to have you in our masterclass tonight. The digital program is yours. Dr. Strenge.
Thanks, Robin. It's great to be here. So why are we here to talk about lateral surgery? Well, lateral surgery really has revolutionized spine surgery with its minimally invasive ability to reach the disc spaces and provide excellent exposure with the best discectomy, the ability to put the largest footprint of implants, and much more stability that comes with that. So you have minimal subsidence. Some of the problems with other procedures like TLIF, it's difficult to get a thorough discectomy. Problems with the ALIF, it can be troublesome to approach levels above L5S1, such as L3-4 or L4-5, where you have to mobilize the great vessels. The lateral procedure has made that much easier and more minimally invasive to access. It all starts with Dr. Luiz Pimenta. He trained in Brazil and really brought lateral surgery to the industry in the early 2000s. He's been involved in the lateral approach and then even taking it a step further. Now, one of his newest projects is working on lateral surgery even in the prone position, which is something that we're going to talk about a little bit later. This picture on the right shows an example of the early versions of lateral retractors to get us to the disc space. Some of them were very complex and difficult to maneuver. As it gained popularity, almost every company scrambled to get to the market with some sort of lateral retractor to get access to that market, which was for the long time and may still be the most rapidly growing segment of spinal surgery. As these approaches started off in their infancy, we were taught to break the table and basically bend the patient to gain better access to the L4-5 level. We started out using smaller implants, such as 18 millimeter spacers with minimal lordosis. But over time, the procedure itself has evolved to potentially try to minimize some of the complications associated with this procedure. Here's a picture showing what we used to do to break the table. And you can see with these type of techniques and trying to gain access and more exposure led to complications, whether it be femoral neural palsies or thigh numbness or weakness. And so with that, the technique has continued to evolve. What we understand is that the stretching of the psoas can cause weakness, compressing on the femoral plexus, particularly for long periods of time, can be a very big issue. Depending on your access, you could have implant subsidence as a result. This is an example of some other systems that have come out that were meant to try to minimize some of these complications. And some of them have been good advances and some of them haven't. We now have angled instruments to reach L4-5. 26 millimeter spacers were used for a short period of time. Some people still use them, but they come with some complications in terms of nerve stretch. There's several two-bladed retractors. And there's all kinds of new other materials that have started to come out that help with implant subsidence and restoring anatomy. Now we're trying to hopefully limit breaking the table, again, trying to minimize those complications, trying to limit retractor time. There's been a whole another segment of spine surgery, such as an anterior to the psoas approach or the oblique lateral fusion. Some surgeons are even going to more of a short docking where they're trying to minimize time in the psoas and actually dissect through to find the femoral plexus and avoid it. Basically, over time, what we've learned is less is more. The more time you spend retracting on the femoral plexus, the higher chance you're going to have a complication. And so you need to be able to get out efficiently, prepare the disc space, and get your spacer in. We've also learned that it's difficult sometimes to put a large cage in, which is what we'd like to do without extra retraction. And so if we were able to put in a spacer, perhaps through a small portal, minimize the retraction on the tissues and the neurologic structures, but then one that perhaps could expand into the disc space, this may be something that's helpful. And of course, the materials matter. Moving more away from smooth peak that doesn't have any type of ingrowth to more of a porous material that participates in the actual fusion. And as you see here, this is an example of that implant, which Dr. Nunley is going to describe a little bit further.
So the question is what's next? And it was both a pleasure of mine to be actually one of the design team members, in fact, the lead design team members of the Ravine retractor, which that was all designed around how do we make a smaller footprint and improve some of the neurological complications that occur during this procedure. And actually, we have actual studies that show that. But then we could go smaller. We could do less than, and we could build the ship in the bottle. And we showed that with the Duo study, which in its original design was a 12 millimeter end plate design with PEEK. But then during that process, we thought, can we keep the tube the same size and then make the implants bigger, which are now 16 millimeter? They're actually 42% larger. So what's next? Well, the mesh implant that has end plates that actually sit on the apophyseal ring, and so we increase that apophyseal ring footage by, as I said, 42%, and then making it multi-planar and expandable, and still being able to get through an 18 millimeter outside diameter tube. So what does that do? It creates a conforming and load-sharing device. Now, if you look at a monolithic implant like we see here, it really doesn't conform to the end plates. It has point contact multiple places, but very little conformity. If you look at how Duo is, it actually conforms better to the apophyseal ring, but then when we put graft into the expandable cage, that actually conforms to whatever that patient's specific anatomy is. And so there ends up being 70% more load sharing surface compared to a 22 millimeter cage. So what does this lead to? So when we put our retractor in, if you look here, this is the 18 millimeter retractor, and you see all the posterior space. This is an artist's rendition of what that looks like. In a traditional 3-blade design, you're really pulling that posterior blade back closer to the TP, you're increasing the stretch forward, and what that does is it really puts a lot of pressure on nerves, which there have been a great many papers that show that that's a time-dependent variable. Well, we're not so sure. In fact, our data shows that time is really not that important when you're only putting 18 millimeters in, because you're not putting the compression on the nerves. When we looked at our clinical results in the Radical study, we looked at mean anterior thigh symptoms on the access side. And these are patients, get this, without pre-op anterior thigh pain. So if you're going to try to study anterior thigh pain, you can't have the noise of people that have had the thigh pain prior to, because that brings noise in. You're not sure what to do with it. So what we did is we excluded anybody that had significant anterior thigh pain, and we looked at all those patients, the remainder, that didn't have any, so that we could really see what's the effect of our approach rather than maybe some other noise there. And what we see is pretty interesting. And leg flexion weakness in the green and leg extension weakness in the blue, and then mean anterior thigh pain, we got a little peak at the 2-week margin. That's okay, that's just surgery. But they all equilibrated and equalized after time. And that's really important to see. This was in the whole study. And then we looked at mean access side anterior thigh pain over time, and we grouped these by number of levels and portal time. And this was 91 patients. So what we see is that even in group 4, where you had increased portal time, you did not see significant thigh pain over that period of time. So this data is extremely compelling in a level 1 evidence type of study to show that what we're doing is real. It's not just theory.
Thank you, Dr. Nunley. That was a terrific presentation. Now I'd like to invite the other faculty members to join us, Dr. Abdelbar and Dr. Koo, along with Dr. Strange. And I'd like to pose a question, and I'll start with Dr. Strange, but let's, kick it around the horn, to use a baseball analogy. Dr. Strange, in terms of your own practice, how has that evolved as you've used the lateral approach?
Sure, thanks, Robin. For my practice, I started out from training using all of the access techniques. We used a lot of A-lift, we used a lot of T-lift, And I had just enough training in lateral to feel confident going out into practice. This was in the late 2000s. My lateral experience started out having my best results. So without a doubt, I gravitated towards becoming more of a lateral based surgeon. When you see the outcomes, doing lateral surgery with minimal access that you can do by yourself without the assistance of a vascular surgeon, and then you see your patients getting up, post-op day 0, and ambulating, saying their pain is gone. It's a pretty powerful thing. So as my practice has sort of evolved through becoming more of a lateral based surgery now, for anything above, from anything L4-5 and above, that it needs a fusion, I'm using the lateral approach.
Dr. Nunley, you were actually part of that design team that created this. And it was really interesting to hear you discuss. You started out with NuVasive at the very beginning, and the nerve monitoring and that whole approach, which of course has evolved. And as you've evolved your practice, I'd love to hear you talk a little bit about the implant, but also how have you come to balance sort of the optimal insertional footprint while also minimizing your retraction and the trade-off between those two objectives?
Yeah, so the great thing about this, Robin, was it's technology driven, right? And building the ship inside the bottle, as people are looking at expandable implants, can be done so many different ways, as you've seen, mechanical ways, etc. But none of these ways conform to the patient's anatomy, because you're always having a mechanical device. One of the things that's interesting about this device is that it used granular mechanics. And granular mechanics is when you have a sandbag. And if you half fill a sandbag, it doesn't really have any stiffness. But when you fully fill a sandbag, all of a sudden it can hold up a wall. And it conforms to that wall. That's number one. Number two is the techniques. So yeah, you can design an implant that can go in small, but how do you do an effective discectomy? Without an effective discectomy, it's not a good procedure. And so that required the development of the tools to do that, of which are relatively few tools when you look at it, but there are tools that help you reach outside of the sphere of the 18 millimeter portal. And one of the most important tools is the Verify balloon, which is a contrast filled balloon that we put inside the disc space. I call it the surgeon humiliator, because I don't care how good you think you are, even still today, I think I got this one, and I'll blow that thing up, and there's a little piece of, you see it, it's in plate cartilage that I missed. And I'm like going, no way. Yes way. And so that's a technology thing. That's a grade your paper thing. And it's also increases the end plate being prepared. It increases all the biology that, again, I don't care what you put in the disc space, you're probably going to get a fusion. But those techniques we developed, and we've really honed them well.
Wonderful. And of course, what we're really talking about is continued evolution of the lateral approach, which actually means expanding its application. And Larry, Dr. Koo, certainly in your practice, lateral is a big part of what you do. How has that evolution past and going forward been for you and in your own practice with the lateral?
Right. I think like so many of us, we've been doing minimally invasive surgery for some time, and we began with MIS TLIFs. If there was ALIF and MIS TLIF in the early 2000s, and the group of us who were working with MIS PLIFs and TLIFs and perc screws and tubular retractors all focused on that. But to the point said earlier, truly minimally invasive anterior access without the need of a vascular surgeon, like Dr. Strenge said, is really what kind of led us down the lateral pathway with Luis Pimenta at the helm, of course. Luis was a pioneer and he still is. But what he taught us is we can get to the front of the spine without necessarily having to do excessive dissection. And because of that, the speed at which we can get to the spine over multiple levels in a kind of an extensile fashion is just striking. And so all of a sudden, one, 2, 3, 4 level lateral surgeries and deformity surgery as a result became within our reach in a less invasive way, in a way that's fundamentally different than how we did it 20 years ago, which were these massive open thoracotomy-like procedures that were in-house for sometimes 2 to 3 weeks post-operatively. So as we become comfortable with its indications, like Pierce said, I myself personally, with everyone, have become better at workflow. And I can't emphasize the importance of that. Having the right set of tools, mastering their use, and for the tools to allow you to do a procedure effectively, quickly, and reproducibly in almost a stereotype fashion. It's like saying we make waffles the same way every time. That allows us to become faster and more efficient and get better outcomes. In other words, we cut out all the unnecessary noise of the procedure to do what's necessary to achieve a good discectomy, like Pierce said, like Dr. String, you get good access, get a good interbody cage, and get a good correction. And that's why the lateral procedure, in many ways, has become the workhorse of 1 and 2 level degenerative deformity surgery in my practice. And honestly, I've been struck by the road we've traveled. We've gone from 2, 3, 4, 5-hour inpatient 2-level PLIFs to 45-minute to an hour and a half 2-level anterior posterior procedures. And it's just kind of striking when you think about that road. So that's my personal evolution. And I know it's going to continue to improve with more and more of the new technologies that come along.
There's an old saying, if you want to make a silk purse, start with a silk sow. What we're really starting with here is a high quality approach to begin with. And all of these iterations, all these improvements have moved it down the road. And it's fascinating for me just to listen to you guys and see sort of how this is coming about and where I think we might be heading, which takes me to you, Dr. Abdelbar. In your own evolution, I know you're going to be our next speaker here, and you're going to talk about the future of lateral approach concepts. But coming up to this stage, how has lateral been a factor in your practice?
Yeah, I think those are really good points, and I really, appreciate you inviting me here. So I have to admit, and I'll talk about this in my talk, I actually didn't get trained a lot in lateral, in fellowship and so on. And I came to Duke, and I met Rob Isaacs, who's one of the godfathers of lateral, and I just really was struck by how well these patients were doing, after these surgeries. And I said to myself, this is something I really need to pick up. And so I made it, my first thing that I learned as a beginning attending was to do laterals. I got to learn it from, Rob Isaacs, who had learned it from Dr. Pimenta. And as Dr. Koo said, when you see how these patients do, it's quite striking how much better they do than compared to your other patients that you do TLIFs for, or even ALIFs for. People say ALIF is a minimally invasive procedure, but it really is not. And the problems with bowel waking up after surgery and so on. This is a big surgery when you do ALIFs and have a vascular surgeon do the approach. And so the ability to do such a good procedure with great outcomes really made me a believer. And it's not something that actually I was trained at in residency and fellowship. But once you see, I had my partner, Dr. Isaacs, and I was like, whoa, why are his patients doing so much better than mine? I quickly learned how to do it.
As my wife said, it's kind of like caveman and fire. Once you see the other side, you can't go back.
That's what's always surprising to me, is to talk to a surgeon that hasn't done a lateral or really hasn't embraced it yet, because it really is that powerful. In my opinion, I feel sorry for someone who's doing a TLIF at L2-3 or L3-4.
Oh yeah,
it just doesn't have to be that way.
Terrible procedure.
No.
So true.
Well, what
it's like stick shift cars. It's like once you get a paddle shifter, you're like, why was I ever doing this?
Well, why don't we, Dr. Abdelbar, if you're ready, why don't we turn the program over to you and give you a few minutes to review the future of lateral approach concepts.
Thank you, Robin. And once again, thank you so much for including me on this amazing panel. I'm going to give my little 2 cents about lateral, and I'm going to give it a little bit of twist and a newer technology and a newer application of lateral, and that's the prone lateral approach. So as I talked about in our discussion, I wasn't really trained as a resident or a fellow to do lateral surgery. And then when I got my first attending job, I saw one of my partners do such a great job with lateral surgery. It's something that quickly picked up. But one of the things that makes lateral surgery sometimes a little bit more difficult is positioning. That positioning the patient in the lateral position is not something that we all grew up with. Also, and this is kind of the impetus of why we would even want to talk about doing prone lateral, is if you need to do any type of posterior work, whether it's putting in screws or whether it's doing osteotomies or whether it's adding on to previous constructs, doing it with the patient in the lateral position is not very ergonomic. We also know from other people's work that when you put the patient prone, you can get increased lordosis just from positioning. So here's a study that came out of Korea showing that just from positioning, you can get about 5 degrees if you put the patient and make sure that the bolsters are placed properly. Another study that just came out recently, also coming from Dr. Pimenta's group and the group in Brazil, is that when you put the patient prone, the psoas actually will move kind of forward for you, but the plexus doesn't seem to be moving. And so that's another thing that's an advantage of the prone lateral. You can also look at just in terms of lordosis, especially between L4 and S1. When you put the patient prone, you really gain a lot of angles and a lot of degrees just from positioning. So putting the patient in a prone position in a open Jackson gives you a lot of advantage just to start off, just getting out of the gate before you've done anything. So I think, when we talk about prone lateral, some of the advantages are that it increases your efficiency, increases your lordosis, and you can use it to treat adjacent segment disease. And I think I'm going to give you a case study here. So this is a patient, typical patient that we see, a 75-year-old. He's had maybe 4 or 5 surgeries. He's currently fused now from L4 to S1. This used to be the bane of my existence. I'm going to be able to have to go through all of this scar. I'd be worried about getting a CSF leak, trying to do a T-lift, and it would just be a miserable day. And I hope to show you that using a prone lateral approach, it really has changed my life and my patient's life. So here are his other post-op films. You can see he has degenerative disc disease at L2, L3, and looks like he's got a spondylolisthesis there. You can see here he's got air in the disc. So that means that this is a perfect surgery for lateral approaches. And you can see he's very well fused at the other level. So this would be a very, very difficult case if you did this open or even minimally invasive. So we actually took him for a prone lateral. So we put the patient prone, we do the lateral interbody, and then I just do 2 paramedian incisions. I take out the old screws, put in new screws, and all of a sudden I'm not worrying about scar, I'm not worrying about CSF, I'm not worrying about anything. You can see how big of a cage I was able to put in there. I'm probably not as fast as the other master surgeons here, but the thing that really strikes me is that this is a bloodless surgery, 50 cc blood loss, right? Whereas if I had done this open, I don't know, maybe I probably lost 400 or 500 just on exposure. This patient cleared physical therapy in 2 days and was home in post-op day 3. So this really is a game changer, I think, in the treatment of adjacent segment disease. You can see here just how much lordosis we were able to put in this case. So I think it really has made a big difference in how I treat adjacent segment disease. Here overall, his overall parameters, we increased his lordosis by at least 5 degrees. So I think we've done him a really good job. I hear from this family that they think that this was a Christmas present. I did him around Christmas time, and this was his Christmas present because he's doing remarkably well. When I think about the other options that I used to use for these types of patients, I kind of cringe and I feel sorry for those patients that I operated on even as late as 2 or 3 years ago.
Thank you, Dr. Abdelbar. That was, and by the way, I was 50 cc blood loss. That's a heck of a stat, I have to tell you, and home on day 3. It's terrific. I want to start with a quick observation, and I think, and again, please comment on this if you don't mind, Dr. Abdelbar. Typically for the prone lateral procedure, surgeons who want to go that direction need to really invest the time to learn it, get comfortable. And obviously you found it to be a very worthwhile approach. Now, for the other members of our faculty, for those of you that have tried it or thought about it, what have been the advantages or disadvantages of using a prone positioning for lateral? And I'll start with you, Dr. Nunley, if you don't mind, and then we'll just, again, sort of go around the horn.
So I think prone lateral is really a great future. Larry's had a lot of experience with it, and I'm sure he's going to say some things in a few minutes. To me, it's that you asked the advantages. The advantages are it's one position, right? And so depending on your program, your hospital, what it takes to flip a patient, that's huge. I'm fortunate to flip from front to back on a case in less than 30 minutes, closed to skin cut. Most people don't have that. And so that's the biggest thing. The other is that it just gets the patient off the table quicker. And that's an advantage. The less they're on the vent, the better it's going to be. It also puts them in a more natural position. When we bend the table, we actually put them in a kind of a worse position. So I think accessibility, there's some challenges for sure, but it's like everything else. One size doesn't fit all. We do A-lifts, we do laterals. We're going to do laterals in the lateral decubitus, but there's going to be some patients that we're going to identify with time that the best way to do them is prone.
Interesting. Dr. Strange, your thoughts?
Yeah, I've experimented with it at least a dozen times, and I'm still in my learning curve. What I would say has been challenging for me has been the fluoroscopy. It's a little bit more challenging as you turn the table to try to increase your access in a more ergonomic fashion. The X-ray techs have to kind of relearn how to center the images and get the spine in the correct orientation. The other thing that I've found to be challenging is in the decubitus position. Some of your largest patients are not that difficult because the abdomen rolls away and is sort of laying anterior to the patient. In the prone position, some of that abdominal girth can make it a little bit more challenging to access laterally through the prone position. But other than that, I think the future is very bright. I've heard stories of some of my colleagues using the prone lateral technique with more of a navigation type system, where as the lateral surgery is being done, residents and fellows are working already posteriorly, taking out some of the existing hardware, which really takes that efficiency to a whole nother level. So I think as we move more towards navigation, minimizing our reliance upon fluoroscopy, then you talk about the efficiency of already being in the same position. I think this is a very intriguing procedure that's going to only pick up more steam.
Boy, those are great observations. And Dr. Abdelbar, I wonder if you could pick up on that same theme. Some of these new approaches, navigation and all these other things actually feed into the prone position, don't they?
Yeah, I would totally agree with Dr. Strange. I didn't show any slides, but I use a proprietary navigation method to make sure that I'm orthogonal to the disc. It's really, really important. And I use ways, so if you're going to make it ergonomically so that you are, not putting a lot of pressure on your shoulders and so on while you're doing this. So I think those are really, really good points. I think another thing that we have to, always think about when you're in the prone position is that gravity is not your friend, especially with the retractor. And so these smaller retractors are better because they don't really, if you have a very bulky one, it can really get in your way. So those are things that you have to kind of take into consideration. But I totally agree with the points about, using navigation to help you in this technique.
So I think one of the other points is really not stated yet, but coming out and leads us quite naturally to Dr. Koo, who will also be doing our next presentation. And that is really all of these things, is this evolution of this approach is leading us into some new areas, outpatient, for example, maybe some additional patient populations So Larry, before you get started on your presentation, where you are going to talk about the outpatient setting, given some of these discussions of the prone position, what key points do you take away from the comments everyone has had, and then your own experience in your own practice?
The prone lateral position is extremely attractive for me for three reasons. One is Dr. Abdubar already said that it gives you access to the posterior spine rapidly. So if there's prior instrumentation, it's wonderful. You can be working on that at the same time. Number two, in lateral, sometimes the hardest part is putting the screws in a lateral position for the reasons that Dr. Strenge said, because it's disorienting, you have to have navigation. There's not a lot of room in the C-arm to work around. So those are ergonomic limitations of putting screws in lateral, which go away with the prone positioning. And finally, most importantly, and this is a comment on lordosis that we've all talked about, in the prone position, you get the most lordosis. And then when you put a lateral implant in, we can do a Smith-Peet or a Pontiac osteotomy and resect some of the spinous processes even to get that maximal correction, hyperlordotic, if you will, or maximal lordotic segmental correction, because without that, a lot of times, even if you put a big lateral cage in, you still don't necessarily get the correction you want because you have to compress across the facets. And if you don't take out, for example, the superior articulating process in some cases, you're going to wind up compressing right back down on the nerve root. So these are the practical ramifications of getting lordosis and maintaining foraminal decompression, indirect decompression, if you will, in many of the cases. And that's where the prone lateral really shines.
With that, that is a natural lead-in to outpatient lateral approach. And Dr. Koo, if you would take the program on and give us a presentation.
Thanks, Robin, again for that. And with that, I want to talk about how lateral, from our perspective, is one of the procedures we're going to do more and more of as we transition spinal surgery as a field and as a procedure into the outpatient setting. Because I think, if anything, these last few years have been trying, to say the least. There have been, the COVID pandemic has forced a lot of hospitals to push into the outpatient setting. And so in that way, it created an unusual kind of premature, kind of rapid onset market force to drive us into the outpatient setting to do single level spinal fusions, which we previously had not necessarily done. But because of COVID, lo and behold, here we are in the outpatient setting, and we realized one thing, that we could do it, and we could do it fairly efficiently. Obviously, the market forces that are at play in terms of reimbursement, cost, hospital capacity, and the demand of outpatients to less invasive procedures mandates that we also, as surgeons, evolve with those market force demands and become more comfortable with minimally invasive surgery. Obviously, all the things we've talked about, minimally invasive T-lifts, minimally invasive A-lifts, minimally invasive lateral, were all done in the inpatient setting for a long, long time. So for us to say that we're going to move these patients to the outpatient setting requires that we become masterful at the ergonomics of the procedure, masterful at patient selection, better at our game in terms of anesthetic and post-operative pain management protocols, and also in our post-operative discharge mobilization plans, and also our follow-up and our surveillance. And these are all the things not specifically related to the surgery that we have to get better at to truly make these procedures outpatient and minimally invasive, safe and efficient for our patients. So all these factors, in truth, have pushed us and now rapidly to evolve towards this. As we also know, the payers are now incentivizing to some degree some of these patients' procedures to be done in an outpatient setting. ACDFs, single level artificial disc, and now lumbar fusions are now, well, they were on the inpatient list only, now they're off the inpatient list, now they're back on. But the point is that I think that we all know which way the bus is kind of driving towards. And so we have to anticipate that and work towards meeting that. And the ASC resources, as a result, have grown. So, like we said, the advantages are in costs, patient advantage, shorter procedure, shorter length of stay. And again, I want to emphasize those benefits come not so much that we would just work really fast or operate twice as fast as in an inpatient setting. It comes from optimization at every single step of the game. It's a Sigma 6 type of pilot flight kind of optimization, that we looked at every aspect of the entire procedure from the time before the patient even walks through the door to the time of surgery, to the time of PACU recovery to the time of discharge, and even at home. And that process has to be optimized. So working smarter and not harder, and certainly not necessarily faster, is the way we achieve shorter procedure times, is the way we achieve more safer surgery and shorter lengths of stay, not necessarily by operating faster, if you will. So to accomplish this, when we look at LLIFs or lateral surgery, we again focus on patient selection, and from that on, identifying patients that are going to be safe to do in an outpatient setting, managing their expectations, let them know, look, this is what's going to happen. You're going to do this, this, and this. 1 hour after surgery, you're going to be out of bed, standing and attempting to use the bathroom, for example. Then you're going to be walking down the hall. Then we're going to feed you a little something. This is the pain medications we're going to give you beforehand, during, and after. And this is what you'll have at home waiting for you. And those expectations management, or that programming, if you will, Jedi mind tricking, is such a powerful factor in terms of determining how patients actually do after surgery by managing their expectations. And then we give them the preoperative, intraoperative, and postoperative pain regimen, and anesthetic and anti-inflammatory and steroid protocols and anesthetic protocols to shorten their length of stay, to ensure they don't have problems like urinary retention, confusion, blurry vision, the things that will get us truly in trouble by discharging patients too prematurely. And that's all encompassed in the ERAS protocol. Many people mistakenly think that the ERAS protocol is just an anesthetic protocol. It's not. It's a patient management protocol that covers every aspect, as we just discussed. And of course, includes the early mobilization protocol. Having physical therapy or a physical therapist on site to mobilize your patient, like after an outpatient hip surgery or knee surgery, is also very critical. And that's part of the ERAS protocol and discharge protocol. And then, of course, having mechanisms in place in your practice to call these people that evening to make sure they're doing okay, make sure they're urinating, walking, not having nausea or ileus, and making sure the next day to follow up as well. These are all the critical things, and having early post-op follow-up are all the optimal post-op surveillance mechanisms that have to be in place. Or in a more graphical fashion, you can see ERAS protocols on these slides. Again, notice there's the protocol covers from the initial visits to the preoperative visits, to the booking of the procedure, to communication of the booking of the procedure, to perioperative services, to anesthetic evaluation at the ASC, the antibiotics, the pain regimen, the anesthesia specific protocol, the drugs we're using, avoiding severe muscle relaxants, avoiding opioids if possible, too much of that. And then in the PACU optimization of the PACU mobilization process, and then of course following them up as well. So you see, ERAS is not just a drug protocol, but it's an entire way of thinking and a way of management to optimize the LLIF procedure. But here's an example of when we do all that, what can we actually get away with, or what is possible, if you will, in a LLIF case. This is a 2-level case, 52-year-old male with 2 years of back pain and leg pain, failed epidurals and typical leg pain with denervation, and it's BMI of 32.5 and some mild medical comorbidities, including hypertension, hypercholesterolemia. And so our goal here is to do a front back fusion, to do for example, a less invasive spineology type approach with a duo TI implant that Pierce talked about quite earlier, and to do a front and then do a posterior interspinous type clamp, in addition to an anterior lateral plate, whose biomechanics are reasonable for a low-grade, not very mobile spondy. So again, 2-level discectomy, cages, lateral plates, indirect decompression, and then same incision, same stage, posterior interspinous plates, which represent, I know in other cases of more mobile spondies, we could put in screws as well, but this for us is also a less invasive option to optimize the 2-level or 1-level front back single incision, single position, single incision front back surgery. And here you can kind of see the workflow. We're doing the anterior portions of 4-5 and then 5-1, 4-5, and sorry, 3-4 afterwards, and you can see that the cage is going in. And then once that part of the procedure is completed, through the same incision, but now aiming posteriorly, we put the devices, the interspinous clamps, through the spinous processes and lamina of L3-4 and L4-5 all in one sitting to achieve essentially that construct, all within about 130 minutes for both the front and the back procedures through a single 1.5-inch incision. So again, minimizing tissue trauma, achieving a biomechanically reasonable construct, and I would be the first to admit, not necessarily the best lordosis in the whole world, but achieving an excellent outcome with regard to the patient's postoperative pain, leg pain, and ambulation shortly within 3 hours post-op. And there's sort of a timeline of what actually happened to the patient, but you can see it was discharged from 8 hours, from about 7 to 8 hours after the time they rolled it in the door and rolled into the operating room. And then, of course, we followed them post-operatively, first a night, that night, the next day, post-op visit 1 week, and the patient had no attributable complications to the outpatient procedure by 3 months. And then, of course, they made a 1-year recovery. They're doing reasonably well. So an example of what can be done. Certainly, we could add posterior pedicle screws, achieve compression like the things we've talked about. But I use this case really as illustrative of what is physically possible when we use an outpatient type-based protocol and ERAS protocol, proper patient selection, and an ergonomically optimized front back type spine procedure. And that is really kind of what the goals are. And again, I don't think it's achievable in every single patient, but I think with proper selection, proper training and experience, and talking to your entire ambulatory surgery center team, getting everyone on the same page, this is certainly a doable thing and will certainly represent a growing evolution of a larger and larger percentage of our spine patients.
Thank you, Dr. Koo. That was an outstanding presentation. Now I'd like to invite all the faculty members to join me. Outpatient lateral lumbar spine surgery that, yes, reduces length of stay and who knows, becomes known as much for its efficiency as a procedure as anything else. If this is truly within our grasp, I think Dr. Koo provided a clear roadmap. From each of our faculty, I'd like to ask each of you, what would be the next steps moving, let's say we want to move to outpatient. Next steps, patient selection criteria. I do want to make a note, multimodal pain management and other factors that can actually lead us to that kind of a lateral future. And actually, I'll kick it off with Dr. Nunley. And again, we'll go around the horn. And I do see we have some questions from our audience. So as soon as we finish here, we'll go to the audience. Dr. Nunley.
So thank you again, Robin, for having this forum, and I really feel honored to be here with the other faculty, all of whom are experts. And I think that you know, it's an evolution thing. You either get stuck in the mud and you stay where you are, or you move forward. And yeah, I've been doing this for 30 years and constantly moving forward to the next step. To your point, and making things better, making it more safe, more efficient, less blood loss, and less stay in the hospital. And again, in the COVID environment, one of the things we tried to do is keep people out of rehab, keep people out of going to any other facility other than home after they're done. And I hate to say it, but we're not done with these kind of events. And so that's also part of the future that we don't like to talk about because we're tired of it, but that's an issue. Care, same or better. Safety, same or better. Costs down. Go home. It's a hard thing to do, but everybody on this panel is part of that, and there's hundreds, if not hopefully thousands more surgeons that agree with that. And so that's a push, but somebody's got to make it really the priority, and we're here to do that.
Well, and again, the people in our audience are learning a lot from each of you. Each of you is really passing along a lot of really interesting information. And I don't want to forget, it is all the things that we've been talking about that Larry explained as you are doing just now, but it also includes the implant itself. The implant also has to evolve. And I'll move to Dr. Abdelbar for your comment on this. Again, if we're moving in this direction, as Larry described into an outpatient approach, it's a combination of factors, not just one or two. Dr. Abdelbar.
Yeah, so I think Dr. Koo's presentation was spot on. It was a pretty amazing presentation. I think one of the things that I've learned is that when you first start out, you're focused on your surgery. But I think we also have to, and as Dr. Koo said, it's a whole experience, right? So your surgery is part of it, right? But the anesthesia, the expectations, what they're going to do, you know, right after surgery, that may be even more important than the surgery. So that's one thing that I'm really working on. I'm hoping to get better at. So, you know, I talk to my anesthesiologists, you know, the night before surgery. You know, I try to make a protocol. I don't want to make a selfish plug here, but I'm doing some of these surgeries now with the patient awake, right? So I can minimize the post-operative nausea and vomiting and so on. And so it's a whole evolution of thinking about, what's our surgical footprint on these patients and minimizing that so that we can really get them back to what they want to achieve.
So Dr. Strange, I'll pass the baton on to you.
Great presentation, Larry. I think everybody's points have been perfect and succinct. One thing I would add, we talk about, and Dr. Koo mentioned this, the COVID pandemic. My partners and I have been talking about it since then. It really has made the push towards outpatient surgery that much more important. We have really been in my area, I don't want to say pushing the envelope, but really just sort of kind of jumping into what we can do now in the outpatient setting that we really didn't feel was possible. And the number one factor that I found is patient expectations. It's not our procedures. I mean, since the very beginning of doing lateral surgery, you almost feel bad rounding on your patient the next day because they're up walking around. A lot of times they have their clothes on. They're waiting for you to round so they can get out of there. It's a procedure that is meant to be done outpatient, especially a 1 or a 2 level. And so, these sort of factors, everything that Larry talked about, I mean, who doesn't want to do more surgery at their surgery center? The patients want it, and they're looking for that concierge experience. And that's exactly what you can do. So the people who are doing this in the right way, the patients are seeking them out, and it's going to help build practice.
Wonderful. Well, Larry, a quick comment, and I want to turn it over to our audience. Again, we have a few questions coming from them, but just close up this discussion before we start our Q&A period. Larry?
I think everyone's kind of hit the nail on the head. We all have had our different evolution to outpatient type of surgery. And I, on a philosophical note, will close it off by saying, like Dr. Abdubar said, it's not just the surgery. It's everything from selection to pre-op discussions to a mental programming to optimization of the procedure awake or with optimal sleep anesthetics to post-operative management. And selection is such a big thing. So I'd sum it up with Sun Tzu's classic saying, the general who knows his enemies will win many battles, as in you know your procedure, you talk to your patients, you know what you're doing, and you will win many battles. But the next line is that the general who knows himself will win all battles. So knowing what you're capable of, honestly capable of, and what you're not capable of doing, and not pushing too early, and not spending the time to be introspective, reflective, and say, what can I do better in my patient selection? What can I do better in my surgical procedures? What can I do better in my postoperative management? Then you'll do a good job in the ASC, and don't move too quickly. I mean, there's no rule that says you have to start doing this tomorrow, but know yourself and know your team and know your ASC. And then I think it's going to come off well, because obviously what we don't want is a lot of premature procedures being done at ASCs and having some difficult outcomes or bad outcomes. And that will set the whole endeavor back, not just for you, but for the overall move towards outpatient surgery in general.
And don't forget that conforming implant. Okay, with that, I'll now turn over to the audience because I see we have several questions in the queue. Thank you for the questions, by the way. And this is an interesting one. Are any of you using any of the new remote patient monitoring codes in your patient follow-up with same-day discharge? And tell you what, I'll pick on you, Pierce, if you don't mind. Remote patient monitoring codes, and then same question for all of you as well.
I'm actually not using any of those codes.
Okay. All right, Larry, do you or Dr. Strange or any of you guys?
We were part of a limited little study with Microsoft to do codes, and we did it in about 6 patients, and we didn't get paid for any of them because yeah, and so that was number one. And number two, we started doing wearables, like they give us their oxygenation, their heart rate, and their blood pressure monitoring as part of that study. And again, the problem is that it's not accepted by a lot of people, including CMS as data. Like cardiologists, they have telemetry for pacemakers and stuff, and that's totally accepted and it's okay. But for us right now, like home nursing and things like that, we're, as surgeons and doctors, we're not apparently qualified to do this. And so it's kind of a new territory. And I think it's going to take some time before the ground rules and stuff, just like Zoom calls, right? Like COVID made it okay for us to do Zoom visits, but now all of a sudden a lot of payers are walking that back. And I think it's the same thing for that right now.
Great answer. All right. Well, we also have another question here. What are the next steps for surgeons who want to move this into an outpatient setting? And actually, I'll go to you, Dr. Strange, if you don't mind, then Dr. Abdelbar after that. So steps surgeons can take. They want to go outpatient.
Well, I think the first step in my eyes would be make it easy on yourself. Patient selection is the key. If you want to try doing a lateral in the outpatient setting, pick an easy level, pick an easy thin patient, make the outcome perfect. And again, I think patient selection is really the key.
Dr. Abdelbar?
Yeah, I would definitely echo that. I think that most of us are moving to the outpatient center, choosing the patients correctly is really important. I think also, building that rapport with the anesthesiologists of how to do the surgery, and something that we don't talk a lot about is regional anesthesia. That's something that's really popular, in orthopedics, and I think that more and more of us as spine surgeons are getting to see that the role of regional anesthesia is very important in that post-operative pain control.
You bet. Pierce, Larry, any comments on next steps?
Go ahead, Larry.
I think my talk really summed up a lot of it, but I think one of the things that is really important that you kind of just touched on with the question about payer codes is you need to also pre-identify which patients are going to be paid for. And I know that's a difficult conversation. And I've unfortunately done a few cases in the ASC where we just didn't get paid because when the payers looked at the codes, like, what, you did a one-level fusion in an outpatient setting? They were like, well, you can't do that because it's not even on it's not off the inpatient list anymore because of the whole flippity floppy that's been going on. So I think understanding that whole kind of evolving world of reimbursement and authorization, because as we all know, pre-authorization is not a guarantee of payment, as they say. And unfortunately, in ASC surgery right now, it's such a pushing frontier that I think you can get some surprises if you don't spend a little more time ensuring that they understand what they're authorizing, so to speak.
Well,
I think Larry's right, and I think that when we look at ASC, I mean, I did my first ASC case in 1999, outpatient ACDF.
Yeah.
And back then, you won't believe the community people that thought I was committing malpractice.
Totally. Oh my God. Yeah.
And, again, like Larry said in his presentation, these are carefully selected patients. We follow them carefully. But I mean, I've been doing this for a while. And like Larry said, we keep pushing it. It's going to be great. But, these implants cost a lot of money. This is, the margins in an ASC are much tighter, and we have to be really careful with how we do this. But it is the best thing for all involved to move these cases as safe as we can to the ASC.
The thing is, all four of you guys are you are leading edge. You're like a general leading the army. You just got to watch your supply lines. Make sure you don't outrun your supply lines.
Yeah.
So look, we talked about we're all progressing, right? Or the technique keeps moving forward. How do you know if the technique you're currently using, this is a question from our audience, how do you know if the technique you are currently using is reasonable for an outpatient discharge? Well, that's a stumper.
Multifactorial.
I think that's a stumper.
That's where you have to have an algorithm. That's where your team has to say, what's the case? ACDF? Is it a lateral? Is it an ALIF? Like an ALIF is a different animal. Are they obese? How healthy are they? Have they had previous surgery? It's a long list that you have to develop algorithms for every specific case and what's your safety margin. I'm a commercial pilot, and so it's like it's like before we go, we have to have checklists, and the checklists have to go boom, 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 and everything has to be green. If it's not green, we don't go. It's a no fly. And so I think that the most important thing an ASC can do with high quality surgeons, like Larry said, if you're not ready to do this surgery, it's not about the surgery itself. It's also about the surgeon and their abilities and their confidences and the whole team. The whole team has to be involved. So I would say have a checklist every surgery. Every surgeon has to know, are they ready to fly? Like me, if I'm a pilot, I got to know, am I ready to fly today? I may not be. I may not feel good to fly. So, so all that has to be in line. But if you develop those checklists, I think at that point, we can make this very safe for patients. But it's not so easy as just walking into a hospital and saying, this patient's getting this surgery, I'm ready to operate on them today.
Larry, any follow-up for that?
I think Pierce hit
Yeah.
the nails on the head. Pierce hit
I think
the nails on the head. But I would say statistics like baseball are a good thing. Pull your last 100, whatever cases, ACDFs, TLIFs, XLIF, and look at, honestly, just find out how long they stayed. You know, if a good chunk of them were leaving within 12 to 18 hours, like say you got done at 5 and they went home the next morning, and
Yeah.
consistently, right? And then you yourself know that, okay, I'm going to get a bunch of in the park singles and I'm going to get on base if I just do ACDFs or if I do one level TLIFs or unilateral TLIFs, whatever the case is. And be honest with yourself and just look at your statistics. Don't think about how you feel, but look at the actual numbers. Because, you know, it's like they say in baseball, the numbers don't lie. Because if you do it 1,000 times, the statistics start to play true. So if your last 200 ACDFs all left the hospital within 12 hours, then you're like, okay, that's probably where we should start, you know? So, yeah.
Well, one statistic that really popped out for me anyway was the 50 was a CC blood loss, Dr. Abdelbar. I got to come back to you about that one. Let's see. Can you elaborate what your typical blood loss is, and how does that compare to other lateral procedures that you do? And how do you do that? I mean, how did you get that kind of a stat?
Well, you know, it's not magic. You know, I think that, you know, if you look at the way that we do the procedure, you know, it's very, you know, when you're going lateral, you're not going to get any blood loss. And if you're doing perimedian incisions, you're staying away from scar, then it really makes things much easier, you know, not to show off, but actually that's not, I just did a case 2 weeks ago where, you know, again, adjacent segment disease, you know, 2-3, patient went home less than 24 hours after surgery. You know, and that's a game changer, you know. Adjacent segment disease, you know, when I was training, that was like you're hit yourself on the head. And I was like, oh my gosh, we're gonna go through all that and, you know, try to take up people's screws and figure out, you know, who, you know, where the defects are and so on. Now we've made things that, you know, we don't have to worry about that. And so I think those statistics are going to be commonplace with these types of surgeries.
That's a great
Nothing
statistic.
makes you look better when you're early in practice than doing an adjacent level lateral after somebody's had an 8 or 10 hour open multi-level fusion with instrumentation done in a traditional fashion with a midline incision.
Yeah.
You do a lateral procedure on that patient and they're like, did we even have surgery? You know, the level of pain is so much less, the recovery is so much easier, and you do somewhat look like a magician.
You're a wizard.
Absolutely.
You ain't a muggle anymore. You're a wizard.
Not much anymore. Well, actually, now when the lateral approach really was picking up some steam, neuromonitoring was a big part of it. Dr. Steger, do you use any neuromonitoring, and how do you know what to avoid and ensure that you're performing a safe procedure as you can on your patient?
Oh yeah, I mean, I think for this procedure, out of all the things I do in spine surgery, I think neuromonitoring is perhaps the most important. I'm actually using the data that the neuromonitoring techs are giving me, and it's changing the outcome of the surgery. You know, if you're getting a very low number anterior and posterior to where your initial dilator is placed as you're starting the procedure before you even dock your retractor. That, like Pierce said, that's a no-go. You're right in between the femoral plexus with your dilator a lot of times. So, I'm taking the information that neuromonitoring is giving me and it's changing the surgery. How often do we do neuromonitoring on cases like ACDFs? And they may say they have a small signal change in the arm or something, but does it really change what you're doing? It's probably nothing. That it's probably positional, and it really doesn't change the surgery. In the lateral procedure, I mean, it's paramount to have the neuromonitoring ability, I believe.
And if I might just add to that in my evolution, because I would have agreed 100% with what Brendan said 3 years ago, but starting about 2 years ago, I started doing direct visualization, of which we have the retractors in the set to be able to do that. And so now that I've done direct visualization, as I said, I would have agreed 100% with Brendan 3 years ago. But now when I get those twos or whatever, I go look. In fact, I'm looking to begin with. And just like we do for a T-lift, I'm now looking direct visualization, seeing the annulus, seeing everything. I'll see a nerve root. Sometimes it's in front of my pin. I'll pull the pin up and I'll move the nerve back, put the pin back in, and then I'll do the dilation. And then I know that I've taken care of the neural structures. And I did that after a vascular injury that was turned out okay, but it was not fun for about an hour. And so that's my new kind of where I've come to revolutionary with the lateral procedure.
Your presentation was really good in that way. I mean, you really showed that beautifully. And it reminds me, your presentation of the radical study, that data was really interesting. Is that going to be available for folks?
Yes, and I will say in the radical study, it wasn't until right at the end of that I started doing direct visualization. So, and Brandon was in that, and everybody else that was in that wasn't doing direct visualization. It was one surgeon recently said, you poke and pray. Which I think is kind of interesting. So rather than poking and praying, I'm dissecting and looking. So I think that's part of the evolution. But before, we had to make big incisions to do that. We can still do that with these small retractors through a small incision and still directly look at what we're doing before we put the retractors in.
That's great. That's a great comment. Larry or Mohammed, any follow-on comments?
Yeah, I think neuromonitoring is very important. I think we're just getting to the tip of the iceberg of what we should believe and what we shouldn't believe. But I do think at this time it may be the best that we have. But I would agree with Dr. Nunley that we need to get better. And there are some very interesting newer technologies that perhaps will help us know where those nerves are, and we're actually working on that right now.
Yeah. I would always gently remind all the folks watching and things, we use nerve monitoring for two things, right? One, to make the surgery safer for us to know where the nerves are and all that kind of stuff. And the second one is for all the dudes who aren't in the room and who might be in the room a year from now, if you will, because in the state of California, in my lovely city of Los Angeles, if anything goes wrong in surgery, I don't care if the guy wakes up with like a shoulder praxia for positioning and you don't have neuromonitoring, our local folks will tell you that's a hard case to defend because, as you know, it's all community standards. So things are very different in Kentucky than they are in Shreveport, Louisiana, than they are in, Raleigh, Durham. But here in Los Angeles, we have more lawyers than you can shake a stick at. I mean, just look at the Oscars like this past week. I mean, it's like we have hundreds of lawyers who are willing to do the other side of the case right now. Like literally, like they were texting like when it happened, So, but the difficulty is that you always want to remember that. But to your point, I think Pierce said the most important thing. The lateral is evolving like an ACDF it has been. Like we would never poke something into the neck and just go look and go, oh, okay, it was good. So I think the natural evolution of it, as we become comfortable with the approaches, we start to do it like real surgeons. We look a little bit around, we move stuff out of the way, we sweep things out of the way, we cauterize things, we clip things. And that's just like how you do an ACDF. And I think from that perspective, the lateral is evolving that way as well, as we become comfortable working down these longer corridors, which previously is more in the purvey of like general surgeons, vascular surgeons with the long instruments. And I think that's what Pierce is really saying. So as you become comfortable, you rely less on the neuromonitoring and more on our good old fashioned eyes and experience in our hands. And that's how we get it done safely. But I would encourage you not to abandon neuromonitoring, especially for those of you
100%
working in
correct.
California or New York or
Right.
Chicago, Illinois, or Miami, Florida.
But you can do, you know, like and part of improv, when I learned how to do improv, it's like not yes, but yes, and. So this
Exactly.
is a yes, and. So yes, and you can do both.
It's like you'd never turn off your VOF or your GPS or your autopilot.
Negative.
You can, but you're not going to.
I want everything I got.
Yeah.
This is adding another instrument.
You ain't gonna pull a JFK, exactly. JFK Jr.
Yes, and one final question, and I just want to say, you guys are the best. I have to tell you this. I'm having so much fun with you guys, and that this whole presentation was so good. It's, you know, I hope a lot of folks see this video afterwards. It's a great way to learn, and each one of you just wonderful. So I'll just close with something near and dear to all our hearts, and that's reimbursement. So if you're going to move this to the ASC, is your reimbursement going to be affected? Do I get less? You know, what's the reality here? And we'll close on a money question. And so I think I'm going to start with you, Pierce. I hope you don't mind. Hit the money question, then Larry, then Dr. Strang.
So the money question is, you got to be careful. And in the ASC, the margins are much tighter. Insurance matters. Insurance companies, implant costs, all these things have to be really well managed, and managed on a case by case basis. Very different than a hospital. So just, you got to have a great manager. You got to look at that. You got to work with it. It takes more time and effort. But yes, we will be able to move all of these cases into an ASC in the future. But the evolution, like Larry had said earlier, like Brandon had said, is going you got to be careful and slow. You can lose on a case or two. We get that, but you can't lose on a bunch of cases. And you just got to go that route.
Larry.
Pierce said it right. You can lose. You have to make on 80%. You lose on 20%, and that's kind of Moneyball numbers. But always remember that, as far as we know now, outpatient ASC reimbursement is based on DRG, right? DRG and CPT. I'm sorry, CPT. Right. But the key is, you can't have the full Monty for every case. In other words, you're not going to put in a cage, a plate, 4 pedicle screws, BMP, biologics. I mean, your ASC will close down tomorrow. So you need to pick the patients that are going to fuse. And I'm not saying to do the minimal instrumentation, but do what you need to do to get a good fusion outcome, like Pierce saying. And so you have to think about that, especially on the front back fusions, because those are the big money spends. And you really do have to think about that and get contracts, get level procedural pricing from your vendors so they can work with you. And you're going to lose on 20%. So you should talk to the vendors and say, hey, for that 20% of cases, can you give us a break? Can you give us an extra break for those? We'll make it up on the regular ACDFs and the one level whatevers. But the bigger ones, like the front back fusions, everyone's got to be in on the same team, and everyone's got to give you the super bonus discount and friends and family pricing, so to speak, on every level.
Yeah. Great comments. Brandon?
Yeah, I would agree. For me, actually, the biggest limiting factor to moving lateral surgery to my surgery center is insurance coverage. In my area, my biggest insurer is Anthem Blue Cross Blue Shield, and they follow Medicare guidelines, just like Larry was talking about earlier. It's the flip-flop, whether or not it's an inpatient code or an outpatient code. And generally, for me, that code has been inpatient only. And I have very few insurers that will allow me to do lateral procedures at the surgery center. So that's step number one. But in the few cases I have done, yeah, implant costs are the key, and you really have to have that penciled out and know exactly what your reimbursement expectation is, because you don't want to lose cases, especially if you have ownership, which most of us, for taking cases there, we probably have some sort of ownership interest, and it matters. So, you're not talking about losing money on one shoulder anchor. The spinal implants, the market is fairly high, whether it be screws, but particularly spacers. The price for those implants are, significant. And so it can make a big difference on your, the end of the day profitability. So it's just something you have to be very careful with.
You bet. Muhammad, you get the last word, my friend.
Well, I'm the last person to talk about money since I think the only one in academic right now. So
Well, I think then that's the final comment. You become part of an academic center.
It doesn't matter as much to me, but I think the inpatient codes are really, really important, and insurance companies are flip-flopping depending on COVID and so on. So we'll see how that goes. My prediction is that in 5 years, there will be nothing on the inpatient only list as it comes to spine. Because
I think you're probably right.
I think more and more will be proving that we can do these safely.
I think that's right. I want to, before we leave, I would like to just say, first of all, thank you to Aubrey Bork, Dan McPhillips, Garrett Gansky. I want to give my personal opinion. These are the folks at Spineology that really put this all together and assembled this amazing faculty. In my opinion, humble opinion, Spineology is the Apple computer of our industry. I'm just saying it right now. I think it's a cool company. And I'm not just saying it because I'm also from Minnesota. It is a cool company. So guys, everybody from Spineology, you rock. And Dr. Nunley, Dr. Koo, Dr. Strengi, Dr. Abdelbar, gentlemen, have a great night. And we will see you all down the road.